سلام عرض میکنم خدمت همه دوستان. امروز یک شنبه 26 ژانویه ساعت 2 بعد از ظهر به وقت شرق آمریکا هستش. خیلی خوشحالیم که با یکی دیگه از وبینارهای پاما در خدمت همگی هستیم. امروز میزبان خانم دکتر مینا مصطفی هستیم. قراره برای ما یک سخنرانی داشته باشن در رابطه با اورال هایجین، اورال هالت و اوکلوژن. از آقای دکتر شکوه امیری میخوام که لطف کنن و خانم دکتر رو معرفی بکنن تا بتونیم شروع بکنیم برنامه رو.
خیلی متشکر از شما و از خانم دکتر که قبول زحمت کردن روزی یک شنبهشون رو در اختیار ما بذارن و از به همکارانمون، اعضا و دوستانی که علاقمند به وبینارهای ما هستن. این دومین وبینار در به قسمت دندان پزشکی ما هستش. میدونین که پاما هم به قسمت پزشکی داره هم دندان پزشکی. این قسمت دوم هست و قسمت به اصطلاح دندان پزشکی ما بسیار فعال هستش. خانم دکتر که به دنتیست هستن و اندودانتیست هستن و از دندان پزشکان پرسابقه در آمریکا هستن، مدت زیادی در آمریکا به اصطلاح مشغول به کارشون هستن، لطف کردن و اعضای ما هم هستن لطف کردن که بر ما در این مورد خیلی مهم صحبت بکنن. من بازم سپاسگزاری میکنم و از خانم دکتر خواهش میکنم که شروع بفرمایید.
خواهش میکنم. بعد از ظهر یک شنبه همه بخیر. خیلی ممنونم که وقتتون رو گذاشتید برای من متاسفانه به فارسی بلد نیستم زیاد بگم، چون که همه به انگلیسی خوندم، ولی هر جایی که اشکالی پیش اومد لطف بفرمایید که من به فارسی هم توضیح بدم. اجازه بدین که من اسکرینم رو شیر بکنم با شما و اورال هایجین و شیر هیر. Okay. Okay. It's connected. Okay. Oral hygiene, it may seem very simple, but it has very large effect on systemic disease. Let's start with the history of oral hygiene. Believe it or not, oral hygiene has been practicing since early 2500 BC to 3000 BC by Sumerian, ancient India, and ancient Chinese. Sumerian elaborately decorated gold toothpicks that found in excavation in Mesopotamia, which this suggests that that era, they had interest in oral hygiene and oral cleanliness. Medical work of ancient Chinese and ancient India developed one chapter in medical work on oral health, oral diseases, gingival and periodontal diseases. Based on ancient Chinese medical book, the oldest book by Han T.I. written in 2500 BC, he categorized oral diseases in three categories. The first category is inflammatory condition. The second one, disease of soft investing tissue of the teeth. And the third one, dental caries. So in that era, 2500 BC, oral hygiene and oral diseases were discussed. Statistically as well as clinically, primary etiologic factor for dental caries and periodontal disease is plaque. Plaque is the single factor of oral diseases. Pathophysiology, periodontal disease involves inflammation and destruction of supporting tissue caused by bacterial biofilm, which is called plaque. interesting enough, 50% of globally of all adults have different degrees of periodontal disease, as simple as a simple gingivitis to advanced periodontitis. 50% globally adult have this problem. What is plaque? Plaque is not a food residue. Plaque is universally described as biobacterial film association of biobacterial film to tooth surfaces. Plaque categorized in two types. Supragingival, which is above the gum, and subgingival. What is subgingival in sulcus? Sulcus is the space that is between the teeth and the gum. The healthy sulcus or pocket is from 1 millimeter to 3 millimeters. That's the healthy tissue. That's the healthy sulcus. Subgingival, supragingival plaque, you cannot see by clinically, it's not visible unless it's pigmented. If you're looking at somebody's mouth, you cannot diagnose whether or not they have plaque or not. In this picture, slide A is a mouth with pigmentation, which shows the area with disclosed magenta color. There are plaque. Slide B, supposedly the tooth has been brushed and cleaned, but after disclosing, there are still some pigmentation which indicative of plaque. That means the mouth cleanliness was not appropriate. Why is that? Because around the gingival sulcus, around the cervical of the teeth, there are pigmentation. That means this patient was not flossing. Picture C, it shows massive accumulation of plaque, which in this case, unfortunately, because gross accumulation of plaque, you can visibly see there is considerable amount of gingival recession and inflammation of gingival, marginal gingival. On picture D, this patient has been brushed but not flossed. Again, when the disclosing factor was used, there are pigmentation. In this case is a different type of pigmentation, which turns to dark brown. That means this patient did not use interproximal flossing to remove the plaques. So patients in these cases, this disclosing factor is very good teaching tool to show the patient that how to brush and floss. On picture E, there is considerable gingival inflammation with considerable gum recession with some pigmentation. On picture F, there are some defect on enamel that it shows the brushing and flossing technique was not effective, and there are some pigmentation and cervical on the upper teeth, and that shows that cleaning is not appropriate to this point. Understanding the link between oral health and systemic health. Periodontal disease link to cardiovascular disease, diabetes, adverse pregnancy outcome, respiratory infection, and Alzheimer's disease. Let's take a look at each system here. The link between cardiovascular disease, the mechanism is bacterial from periodontal pockets enters to bloodstream, cause endothelial dysfunction. Let me see here. And contributing to some that doesn't move. Okay, and dysfunction of contributing to arthrogenesis. When we talk about the periodontal pockets, we're talking about pockets that is more than 3 millimeter. As you remember, the healthy gum tissue, the healthy sulcus is 1 to 3 millimeter. Beyond 3 millimeter pocket, the cleanliness at home would be ineffective or ineffective, and bacteria would exist in the pocket. So that contributing to entering to bloodstream. This is in actually in chronic periodontitis. Systemic inflammation from periodontal disease exacerbate cardiovascular disease because of that factor that goes to bloodstream. The evidence shows increased risk of MI and stroke in patients with periodontitis, untreated periodontitis, and chronic periodontitis, actually. What is the relation of periodontal disease and diabetic mellitus? This unfortunately has bidirectional relationship. What does it mean? Poor glycemic control exacerbate periodontal disease. Patients who have type 1, especially type 1 diabetes, which is uncontrolled with high blood sugar, their periodontal disease does not resolve. And this is the case of catch-23. They don't treat their periodontal, gets back to bloodstream, bacteria, and back and forth. Severe periodontitis increase insulin resistance. Once you have periodontitis cannot be resolved or treated unless it's patient cooperation and can be controlled. But once the bone is destroyed or ligament, periodontal ligament are affected, it's hard to replace them by non-flossing and brushing. Okay, evidence of periodontal treatment shows that there is improvement of A1C by 0.4% when the periodontal treatment are successful. Usually the A1C is improved. Link between pregnancy and periodontal disease. Association is with periodontal disease is low birth weight, preterm babies, and preeclampsia. These are evidence of periodontal inflammation that cause low birth and preterm and preeclampsia. Oral bacteria and inflammatory mediator can also translocate to placenta. During the pregnancy, there is hormonal changes. Even patients with good oral hygiene, they all have inflammation around gingiva and some puffiness and sometimes bleeding. So during the pregnancy, it's very important that oral hygiene improved to the maximum that they could do it. Evidence of pregnant women with periodontitis shows between 2 to 7 times more adverse outcomes during the pregnancy if they have poor oral hygiene and periodontal disease. Relation of periodontal to respiratory disease. Aspiration of pathogen can lead to respiratory infections such as pneumonia, especially in vulnerable patients, especially in elderly people that their health is compromised at times. COPD also worsened when they have patients have with periodontitis, the pulmonary function decreases with a patient with periodontitis. Relation to Alzheimer, gram-negative anaerobic porphyromonas gingivitis DNA has been found in brain of patient with Alzheimer's disease. The mechanism is chronic systemic inflammation and neuroinflammation. They are interrelated. This diagram is very good for patient education that oral infection, periodontitis carries, how they can relate to different organs of the body. As you see, there are commonality between organisms in Alzheimer's disease, cardiovascular disease, GI tract, respiratory system, and adverse pregnancy outcomes. Common oral health issues. In this picture, the lower picture shows a healthy gingiva and periodontium. The gingiva is pink. There is no plaque. On top slides, there is gross inflammation and severe gum recession and severe plaque information around the cervical line. And even between the teeth, this is the accumulation of plaque is so much that you can see with your naked eye. Common health is dental caries, periodontal disease from gingivitis to advanced periodontitis, halitosis, which is a social offense, and oral cancer. Role of physician in oral health. Screen oral health during your routine exams. Educate patient for oral hygiene practices. Refer to dental professional when is needed. Oral hygiene best practice. This is the diagram of routine oral hygiene. Actually, floss goes first. Floss, brush twice at least, and limit sugary food and drinks, and visit dentist at least every 6 months. This is this diagram is the importance of oral hygiene. Oral hygiene is critical for preventing dental and systemic disease. Common practices are flossing again, brushing, and routine checkup. And that shows the flossing technique and brushing technique. A special consideration for a patient. A special consideration for pediatric is educate the parents. A lot of parents, one of the factors that is very important that I need to mention here is fluoride treatment. A lot of parents these days, they object to receive fluoride treatment during the dental visit. And this is the role of the physician, pediatrician, and other healthcare to educate parents for safety of use of fluoride. We have fluoride in water 1 per million, which is very safe. And when people use bottled water does not have any fluoride. So we have to educate parents, if they use bottled water, they have to replace the fluoride in some way. Geriatric oral health is addressing the dry mouth. A lot of geriatric patients due to some systemic disease and some medication, they have dry mouth. The other important consideration for geriatric population is care of the prosthesis, which is denture and partials. And a lot of geriatric people they sleep with their prosthesis, which is prohibited during sleep, that cause severe fungus infection. So that has to be addressed in geriatric, especially patient in nursing homes. Chronic disease management, diabetic patient, and periodontal care, we have to address that. Oral health tips for physician. Recognize signs of poor oral hygiene, gum bleeding, tooth pain, and lesions. Integrate oral health question into history taking, promote interdisciplinary care with dental professionals. Okay, conclusion and takeaway. Oral health is integral to overall health. Physicians play a pivotal role to promoting oral hygiene. Collaboration with dental profession enhances patients' outcomes. Image is a smiling, diverse group of patients and healthcare providers. Questions and discussion. How can we better integrate oral health into primary care, and also what are the barriers that you face addressing the oral health?
Do you want the participant ask the question at this time?
Yes, they can. I have 5 minutes, 5-6 minutes to answer the question. Yes.
Okay. My first question.
The next subject is totally different from this one.
Yeah. Yes. The question here from me is that the issue of insurance coverage, because yes, as you know, the insurances do not cover many of the things that dentistry is practicing, like medicine, which is cover more. How the dental group and associations are trying to solve this problem, so it will be easier for the patients to be referred and be taken care of by the dentists.
Okay, yes. Actually, on Thursday, I received an email from ADA, American Dental Association, the president of ADA marching to Capitol Hill to protect. There is a legislation right now. I'm working in actually right now in Montgomery County Health Department, which we see all the patients without any insurances. I don't know other communities, but I know in Montgomery County we have health department sees all the patient, and I am part of that. And the other options they have, there are nonprofit organization, dental clinic that they can refer to. And one subject, every child, as far as I know, they have Medicaid coverage. But the problem with Medicaid, I know in DC, they have to renew it every year. So if they neglect to renew their, their paperwork or their coverage, they're left without any protection for a while.
Yeah, but this is such an important issue, especially you mentioned cardiovascular,
yes,
system, diabetes, everything will be affected. So it's very related to medicine and dentistry together, and is really ununderstandable why is not the insurance coverage is better for the dental care like in medicine.
Yes, as you know, a lot of people graduated from dental and medical schools with a huge tuition, problem. So a lot of private practice, which there is also obsolete, is gone. But imagine somebody who just graduated and has huge debt on their tuition. They're not able to take. I did in my practice, not many, but I did some pro bono work. but they can contribute their time to go to, like I know there are Catholic charities clinic, there are other charity clinics. They can donate their time, half a day a month, half a day a week, half a day every couple of weeks, to go and treat these uninsured children or adult. So that's one way they can contribute if they cannot see in there. That's I think is our duty to do that. The other thing is legislative. I think medical and dental, they have to collaboratively go to march to Capitol Hill and do something about that. This is really embarrassing. There's another subject when you mentioned about the insurance in next subject, that there is a serious problem with the malocclusion, that they need a simple solution and no insurances covers this. This should be part of the preventive care, not the patient burden. Somebody who does occlusion without his knowledge or her knowledge stick with the bill which they cannot afford it, and they suffer.
I agree.
Unfortunate. But I think if I get to that on next subject, that is really is role of the physician. I get a lot of patients referral for pre-surgery. As you know, you're a transplant surgeon. I get a lot of patients for dental clearance or oral infection clearance. And honest to God, sometimes it takes several months to clear them, and they don't understand it, and they're anxious to get there. But you know, the insurance, the coverage, this and that, prevent that.
Yes. And unless we get a clearance from dental practice, we do not list them, because we know that after transplantation, being on immunosuppressive medication, their infection flare up badly and they may die. So it's very important to address that one. Yeah.
In dental infection, if it's not treated, become abscess on upper jaw. If the infection I tell them, infection directly goes to the brain, and in lower jaw directly goes to the heart behind the space, and then it's a killer.
Yes, that's correct. Okay, are there any other questions? If not, Dr. Mostofi will go to the second subject.
Yes, there are two questions.
Okay.
One is by myself, and one is by someone called iPhone. And the other person had raised his or her hand before me. So if anybody else has question, please go ahead, and then I will ask my question.
Hello?
Yes.
Can you hear me?
Yes, I do.
Oh, yeah. My name is Hassan. Thank you very much for the great presentation. I'm actually an MD, but before medicine, I studied dental prosthetics. So that presentation sounds really great to me, because you mentioned that there is there is actually an association between periodontal diseases and some kind of medical conditions, for example, heart disease and diabetes mellitus, these things. So I wanted to ask you if you have any document or if you have seen any documented study which proves association between periodontal diseases and some kinds of autoimmune diseases, for example, multiple sclerosis. I know actually, partly, for example, in diabetes mellitus, also a kind of autoimmunity is concerned. But I'm asking regarding specific direction between periodontal diseases and any kind of autoimmune diseases, such as, for example, MS. I appreciate it beforehand for your response.
So Dr. Mokhtari was to answer that, right? I don't have any, because those are looks like a genetic and degenerative disease. I think if somebody has degenerative disease before they have a periodontal disease, I don't know how can I prove it that these two link to it.
Yeah, okay. Thank you very much. I appreciate it.
Dr. Mokhtari, if you have any comments in that regard, please unmute yourself. Thank you.
I don't
You
think.
are still muted. Please unmute.
Hi.
Yes.
I wanted to have a comment that the insurance companies should cover at least two issues in oral pathologies that is so close to the to the medicine. The two subjects that Dr. Mostofi is discussing are not really dental problem. It has some overlap between medicine and dentistry. Both periodontal disease and malocclusion, these are the subjects that they have a lot of overlap between medicine and dentistry. So the insurance companies has somehow to get involved to pay for these two subjects, and they don't compare it with the aesthetic dentistry and the other or prosthodontology. These two subjects are tied very deeply with the medical problems.
Well, as I said to Dr. Shukru Amiri, I think the problem that we have is the legislative problem. Why we have more coverage in medical and we have limited coverage in dental. Dental coverage per year, if you have good insurances, maximum of 3,000 a year. And that 3,000 a year is not, they have to pay some copay, and copay is high. So something has to happen right there, that they have equal coverage for dental and medical. That's something that people who are in authority in medical community and dental community get together, march to Capitol Hill and demand this.
I think that's the way we have to resolve the problem, because a lot of people have these two problems in their oral and their occlusion, which is really a medical problem rather than being solely a dental problem.
Yeah, there is
These
a
are
piece. Yeah, go ahead.
So there should be some legislation to cover this by insurances, because they make a lot of problems in the general medicine and the specialties, as you mentioned, in cardiology and endocrinology, infectious diseases. Yeah, I mean, during the time that I was active in medicine, there were a lot of endocarditis which flare up by the periodontal disease. So this is not purely a dental problem. That is my point.
That's the oral infection is a focal infection. Like I get a lot of people like Dr. Shakwamiri, and people who need to have transplant, or people who need to have knee replacement or hip replacement or mitral valve replacement. They come for clearance. So they have, this is a major focal infection in entire body.
Exactly. Thank you.
You're welcome.
خب نوبت سوال من هستش.
بفرمایید.
مصطفی، دست شما در نکنه، پرزنتیشن بسیار خوبی داشتین و بسیار مفید بود. در رابطه با ادورس افکت های بیماری های دهان و دندان من میخواستم سوالی کنم که شما اشاره فرمودین و دوستمونم یک سوال خیلی خوبی رو فرمودن در رابطه با آتو ایمیون دیسیز اسوسییشن. و من میدونم که بسیاری از، به عنوان یک پاتولوژیست، من میدونم که بسیاری از مریض ها بعد که میان پیش شما، بعد که اینفکشن دهان دندان رو شما تشخیص میدین، بک‌گراندش رو که به اصطلاح اندوکاردایتیس باشه، و یا حتی در بسیاری از تومورهای دهان دندان شما اول تشخیص میدین وقتی که یک مریض یک لیژن داره، بعدا میاد پیش دکترها و پاتولوژیست. این بسیار خوب هستش. من فقط میخواستم ببینم که وقتی که شما فرمودین که بین به اصطلاح بیماری‌های دهان دندان اسوسییشن های بین پریترم برث هستش و یا لو برث یا اینکه پری اکلامپسیا هستش، و یا حتی با الزایمر اسوسییشن از این طرف. آیا ریورس اسوسییشن هم داریم که اگر احیانا یک نفر یک لو برث ویت داره یا پری اکلامسیا داره، برعکسش رو ببینیم که خب پس ریشه این ممکنه که در دهان دندان اینفکشن دهان دندان بوده باشه. یا اگر الزایمری ما داریم، چون من روی سری پروژه های الزایمر هم کار میکنم، یعنی از حال بعد ما بیشتر دقت کنیم که اگر مریض ما الزایمر گرفت در سن 60 یا 70، برگشتش رو بدیم عقب به عنوان پریونتیو میجر، ببینیم که آیا روزگاری این مریض بیماری دهان دندان داشته. آیا شما از ریورس اسوسییشن هم اطلاعی دارین در این زمینه؟
من متاسفانه ندارم، ولی اینا میدونید که اینجور استادیا خیلی مالتی فاکتوریال هستش. they have to have control. این دهان دندان همونجور که اون دیاگرام داشتم خیلی باکتریا هستش. اینا آلزایمر رو به یک باکتریا گرام نگاتیو اناروبیک لینک دادن. بنابراین شما اگه بخواید همه اینا رو ریورسش چیز کنید، هر ماکرو باکتریا رو باید ایندیویدوالی آیسولیت بکنین و لینکش رو پیدا کنین به اون دیزیز. So این requires a lot of money and research, and who is going to do that I don't know.
حالا در مورد الزایمر من چون که تیشوهای زیادی داریم با همکارای نوروپاتولوژیمون صحبت میکنم که ما بتونیم حداقل شاید بتونیم یک پروژه جالبی رو بتونیم شروع کنیم.
اون دیاگرامی که من نشون دادم دیدین که پاتوژنیسا تقریبا کامنالیتی هستش. جینجیوایتیس تو تمام این transmission of the bacteria. So هر کدومش اگه جدا جدا بخوان آیسولیت بکنن و استادی بکنن خیلی خوبه.
بله، متشکرم، مرسی. به نظر میاد که سوالی دست کسی بالا نیست، شما میتونید قسمت دومش شروع کنید. بفرمایید.
بله الان میرم تو قسمت دوم. ببخشید من اینو باید استاپ کنم برم تو اون یکی. اجازه بدین. توی Occlusion. نه Occlusion. Okay. Looks like it's getting there. Okay. The second subject is occlusion. What is the occlusion? Occlusion is contact relationship between maxillary teeth, upper teeth, and the mandibular lower teeth during the functional activities like chewing or at rest. So connection of upper to lower teeth, this is occlusion. What is the importance of occlusion? Proper occlusion ensure efficient mastication, speech, and prevent oral health problems. What is malocclusion? Malocclusion is misalignment of the teeth, which cause local and systemic complications. The objectives: to understand impact of occlusion on oral and systemic health and its relevance to multidisciplinary care. In this figure, you see on the left is a perfect occlusion. The perfect occlusion is upper teeth and lower teeth is a group function, comes together on long axis of the teeth. If you notice, the midline of upper tooth is exactly coincide with the midline of the lower teeth. This is a perfect healthy occlusion. On the right side, you see malocclusion. This is one of the type of the malocclusion. It's type 3 with bilateral crossbite. So the lower jaw covers the upper jaw. This is a gross malocclusion class 3. Anatomy of occlusion. The key components is teeth alignment, proper position of the teeth in the arch. You know, sometimes the teeth are disposition, like rotated, is a technical rotated. If I say rather than be facial lingual is rotated to distal lingual. So the tooth are rotated. You see canine in some cases, canine in some cases, lateral incisor in some cases, even bicuspid are disposition. TMJ, or temporal mandibular joint, connects jawbone to the skull, enabling a movement. Actually, the upper jaw maxillary is stationary. The movement happens with lower jaw through the muscle of the mastication and condyle. The lower jaw goes forward, backward, left, and right. Muscles of mastication facilitate chewing and jaw movement. The same thing, the lower jaw moves, the upper jaw is stationary. Periodontal structure is also part of the occlusion, support teeth and absorb occlusion forces. So all this component is part of the anatomy of occlusion. If one is defective, malocclusion happens. Type of occlusion, one is ideal occlusion, the perfect alignment of the teeth and the jaw, which we saw on the first picture previously. Malocclusion is when there's deviation of the proper occlusion, and there are different classifications, which we don't have time today to go over each classification. There are class 1, class 2. Class 2 is has two divisions, division 1, division 2, and class 3 that you saw the picture. There is overbite, underbite, crossbite, crowding, and also open bite. Open bite could be local factor like thumb sucking after age 2, and it could be a skeletal. Open bite is very critical, that we discuss when I get to that later. This is the picture of the anatomy of the TMJ. TMJ joint is the only joint that does not have synovial liquid fluid. The only disc, the only movement that make it easy is the articular disc. That is in case of the TMJ problem, the disc get damaged and very painful and cause a lot of problem. Lower jaw is actually attached to base of the skull only with the muscles. There is no other attachment, only with muscle of the masseter, pterygoid muscles, medial and lateral pterygoid muscle attached to base of the skull. Malocclusion and its effect on oral health. Malocclusion causes periodontal disease. Excessive occlusal forces can cause trauma and cause massive bone loss. Tooth wear, we see next picture, cause attrition, abrasion, fracture, teeth fractures due to imbalance forces. Temporal mandibular disorder cause pain, clicking, and locking. Systemic implication, masticatory dysfunction, which if you have malocclusion, you cannot chew properly. When you don't chew properly, cause GI problem and nutrition problem. Chronic pain, TMD, contribute to headaches and neck pain, and that's very disturbing to some people. Sleep disorder, malocclusion, and cause also to obstructive sleep apnea. This picture, the left side, you see gross attrition due to forces of bruxism and grinding for many, many years. This also cause a collapse of the bite, which we call it vertical dimension. When there is gross collapse of the bite or loss of vertical dimension, the forces, rather than forces contribute among the occlusion, among the group function of the teeth, the forces because of the stress directed to condyle and directed to TMJ and cause TMJ problem. On the right side, you see because of the malocclusion, gross bone loss, you see the cementum is showing, and lower right, left, there is considerable of bone loss. TMD, temporal mandibular disorder, the etiology is trauma. Trauma could be from parafunctional habits. What is the parafunctional habits? Bruxism, grinding, or malocclusion also cause trauma. In occlusion, this is a group function. That means all the teeth should come together at the same time. If a group of the teeth do not touch, that cause a lot of trauma to supporting tissue to teeth, cause tooth fracture, mobility of the teeth, and loss of bone, and inflammation of periodontal ligament. Symptoms, as I said, is jaw pain, difficulty chewing, severe facial muscles, spasm, and also ear-related symptoms like tinnitus. Treatment usually is occlusal adjustment, splint in some cases, physiotherapy, and severe cases, surgical intervention. On the left side, you see a healthy TMJ joint. On the left side, this is just, I wanted to show you the destruction of the disc. This infection has not related to occlusion. It's just showing the thinning of the disc when you lose height, vertical dimension that I mentioned before that affect the discs and become very painful and discomfort to the patient. Bruxism and occlusal trauma. Bruxism is involuntary grinding or clenching of the teeth, usually happens during the sleep. Also, people who work with the computer, their job is constantly looking at the computer. They don't have any pay attention to their, body function. They clench during the work, and I had cases on that. Usually bruxism associated with stress, anxiety, and sleep problem. Occlusal trauma, what is the occlusal trauma? Excessive force cause damage to the teeth and periodontium, and also TMJ. The forces from the malocclusion also transfer to TMJ by grinding and affecting of condyle, pressuring the discs. Types are primary is trauma, the secondary is trauma, which compromise to periodontium and periodontal ligaments. Occlusal forces beyond physiological limit can damage periodontal disease and cause gross bone loss. Adjusting the occlusion helps reducing the mobility. In terms of mobility, when the occlusal forces is constant, periodontal ligament become inflamed and bone loss and cause teeth mobility. When the tooth is mobile, cause fracture and discomfort. By adjusting the occlusion, you prevent of teeth mobility. Preventing further bone loss by adjusting the occlusion, enhancing the long term of the restorative phase, and also recommending wearing costume occlusal guard. Here is when Dr. Shuku Amiri mentioned something about insurance coverage. This costume occlusal guard is a preventive care, and no insurance covers that. Unfortunately, convincing the patient to pay for such a device, which is a couple $100, is very, very difficult, and insurances don't cover. And here is the problem that we have every day. I don't know what else to do with the insurance company. Impact of occlusion on systemic diseases. TMD malocclusion leads to chronic pain, stress, and postural issue. So somebody who has chronic pain, they really go under a lot of stress and their functionality decreases. Bruxism and cardiovascular. Again, the bruxism linked to stress, which is cause systemic inflammation, elevate blood pressure, and cardiovascular risks. Periodontal disease, occlusion traumatized, again, exacerbate periodontal disease, increasing systemic inflammation and risk for heart disease and diabetes. And also malocclusion can narrow airway and worsen the obstructive sleep apnea and cause systemic disease like hypertension and cognitive decline. And also poor occlusion affect chewing and leading to GI problems. Here are two cases that malocclusion can be treated by simply having braces. And in other case is with prosthodontic, that means crown and bridge. Actually, somebody who get for first time a crown or bridge, if they never had anything else in their mouth except their natural teeth, the occlusal adjustment is very important. They have to make sure that the group function is not disturbed. And sometimes if there is malocclusion that can be corrected with one or two crowns or bridge, that also is corrected the malocclusion and cause normal function for the contacting teeth to teeth. Multidisciplinary approach, collaboration with medical profession, TMD and sleep apnea management with ENT specialists. For chronic pain, refer to pain management. For people who cannot chew, they have to have a nutritional guidance that so they can have proper nutrition. Case example is patient with malocclusion, chronic headaches, and sleep apnea can be successfully treated with interdisciplinary care. Clinical evaluation assessment tool is when you see the patient visual examination, look at the teeth alignment, pattern of the wear, if there is any attrition or recession. Using articulating paper, it's a thin paper that is color coded, used to see the contact point between the teeth. And as I said before, the occlusion is a group function. If you use the articulating paper and you don't see all the contact point, that's a red flag to have occlusal adjustment. Usually we take the impression and have the study model and use the articulating on our study model and transfer the correction to patient's mouth. Screening patient for TMJ palpitation is very simple. Examination, when patient comes, we use two pinky fingers put in the patient's ear and have them to open and close couple times, and you feel and hear the malocclusion and clicking and locking the jaw. Preventive measure is regular dental visit for the early detection, especially in open occlusion in children. It's very important to have early that prevent future surgical intervention. Patient education for oral habits like clenching and grinding, they have to seek treatment. Therapeutic information, occlusal splint for bruxism, this occlusal guard. There are different type of occlusal splint. One relates to TMJ, that orthodontists, they make that. There is for bruxism, the regular dentist, the general dentist can do that. Orthodontics treatment also alleviates some of the malocclusion. Bite adjustment, this is very important. They have to ensure that the patient have group function, group closure, and not just one or two teeth occlude on the upper and lower jaw. Call for action, encourage medical professional, include occlusal health in the patient evaluation, strengthen, make referral to dental specialists for occlusion-related concerns, promote awareness of systemic implication of occlusal issues, and that's that.
خیلی ممنون خانم دکتر. خیلی چیزا یاد گرفتیم. به نظر میرسه آکلوژن پرابلم خیلی ها هستش.
بله.
من خود تکنیکال این سوال میکنم.
بفرمایید.
به اصطلاح upper jaw is ahead or in front of the lower jaw.
بله.
And if they want to correct it, because the mandible cannot be moved from its anatomical position, so the only will be the direction of the or angulation of the lower teeth to touch better the upper teeth, or how they do that?
No, okay. You're talking about the malocclusion. Okay, malocclusion, it could be skeletal. Okay, I didn't. Okay, malocclusion could be skeletal or teeth related.
Mm-hmm.
Okay, suppose. Okay, imagine a couple. One couple, a man has a small jaw, and the mother has big teeth. The poor kid gets a small jaw from the parent, from the dad, and get big teeth from the mother. So in that small jaw, 32 teeth has to be, space in this. So what they get here, they get massive crowding. Okay. Now, in case of the skeletal problem, it's very important. Pediatrician or anybody who sees a patient, if they see discrepancy with the jaw closing, if the lower jaw is way, way back or way, way out, or the upper jaw, maxilla is way, way out, that's the time to refer to orthodontist. Because at that age 4, 5, 6, the bone, the cortical bone of lower jaw and the maxilla are very soft. You can use devices, fixed appliances to, usually the lower jaw grows faster in class 3. They put devices, they synchronize, they retard the growth of the lower jaw until the upper jaw catch up. That's in case of the class 3. In the same thing for open bite. If the skeletal with these devices, they can correct at very early age. But that in some cases, this is not complete. They may need second phase of orthodontics, which comes around age 12, 13 years of old. So they synchronize by putting some devices to retard the growth of the whatever jaw is faster.
Very good. So it's a complicated issue. It's
very
not
complicated.
easy. Yeah, it's not an easy. Thank you so much. It was very informative. Is there any question to Dr. Mostofi?
Dr. Mokhtari has something.
I really thank PAMA to put this very rewarding lectures in their program, because it was very interesting to me and to a lot of physicians that they don't know what the impact is on our specialty by the dental problem. I just had a comment or a question. Dr. Mostofi did not really put too much interest on the earache. One of the most common symptoms of the malocclusion is earache. They have pain in the ear, and
Yes.
usually they come to the physician, either ear or ear surgeon or their general practitioner, and talking about their pain in front of the ear, or they cannot really localize it, whether it is outside the ear or inside the ear. And just one simple examination that you put your finger on the condyle and make the patient open and close their mouth and see the pain is not inside the ear. And by the ear examination, you can confirm that the problem is in the jaw joint. And this is the main symptom, that is the interaction between between malocclusion and ENT
ENT.
problem.
Yes.
And usually it's forgotten and they don't put too much attention. You talked about the skeletal portion of the causes of malocclusion, which is mostly related to many sophisticated cases of endocrinology and skeletal problem like uh, uh, acromegaly and other
Yes.
problems that they may have bronchitism or retrogenia and so on, or microgenesia is a real problem with the occlusion that they have, and they usually are referred to the otologist by earache. And that was my only point that I wanted to bring up. And anyway, I appreciate Dr. Mostofi and Dr. Shukamiri to put that much consideration on the field of oral and oromaxillofacial problem that have so interdisciplinary a common problem. Thank you so much.
You're welcome.
And thank you so much, Dr. Mukhtari. Actually, we are waiting for you to give a webinar on your expertise. I know that you have a very deep expertise in the head and neck and things. So hopefully we'll hear from you also one day.
Thank you so much. I will.
We have one more question. Please go ahead with iPhone. Yes.
Yeah. Hi again. This is Hassan Kabiri.
Yes.
Actually, that was a great presentation. But I've got a question regarding TMJ disorders.
Yes.
Yeah, as far as I can remember, actually I have two questions. Is there any association between TMJ disorders and neuralgia, trigeminal neuralgia or tic douloureux? This is the first question. And the second question is that in case of degenerative joint diseases, for example, in the knee, or in some other, let's say, articular lesions such as hip, for example, in the very advanced stages, we have the process or the surgery that is called, for example, total knee replacement or total hip replacement. In case of very advanced degeneration of, let's say, mandible, do we have or has such a process or surgical process introduced, such as total, for example, replacement of the TMJ? And in case that it has been done, I assume that it is just this process, the surgical process, should concentrate on the posterior ramus of, let's say, mandible. Do you agree with that? I really appreciate your comments in this regard.
Yes, there are I don't know if you have aware of there people who come back from combat zones and with a lot of destruction in their facial. There are prosthodontic collaboration of orthodontists and collaboration that they do replace partial or full jaw. But that's very complicated. Usually people who come born from the bomb or something, that the total destruction, or also because of some serious cancer or cancer that cause degenerative too. Then there are, yes, there are, but those are usually done in not private practices, usually in major medical, especially in army, I know they do, and in a lot of major medical facility, because needs a serious a surgical intervention, and it's not one or two. And they sometimes they provide them prosthesis that when they put on their voice on like a maxilla, you cannot recognize this is a prosthesis. Yes, they have been done, but it's very rare. Yes.
Thank you.
Thank you so much. If there is no other question, I would like to thank Dr. Mostofi for this elegant discussion. And as you can see from the question, there is a lot of interest. And actually, I may ask one of my colleagues to talk about the next surgery, which is related to that one, and reconstruction of the mandible and maxilla in the cancer surgery that is practiced in our center. If there is no other question, I would like to bring to attention of everybody that in 2 weeks, Dr. Saidi is going to talk about the effect of climate change on health. And in 4 weeks, I'm going to talk about the benign disease of the pancreas.
Great.
No, it seems that we don't have any more questions. Thank you so much.
Thank you, everybody who's participating. Have a wonderful rest of Sunday.
Thank you. Thank you, Dr. Shukabiri.
Thank you.
Thank you.
Okay, bye-bye.